Welcome everyone. I am Dr. Faran Ahmad from Creighton University, Omaha, Nebraska. Today I'll discuss the global and national impact of pneumococcal infections and how vaccination strategies from PCV7 to next generation vaccines are shaping outcomes in adult populations. This presentation will explore the global burden of pneumococcal disease, the evolution and efficacy of current vaccines, their impact on mortality and clinical outcomes, and the challenges we face in optimizing pneumococcal vaccination strategies. Pneumococcus remains a leading cause of pneumonia, meningitis, and sepsis, particularly fatal among children under 5, older adults, and immunocompromised individuals. According to the World Health Organization estimates, 1.6 million deaths are attributed annually, with staggering 4 billion in economic burden globally. In 2015, nearly half of all pneumococcal deaths occurred in just 4 countries: India, Nigeria, DR Congo, and Pakistan. This distribution reflects the convergence of high population density, limited vaccine access, and high background rates of respiratory infections. The majority of deaths, 81%, were due to pneumonia, with meningitis and other invasive pneumococcal syndromes comprising smaller but significant proportions. These data emphasize that while invasive pneumococcal disease presents in varied forms, pneumonia remains the predominant and most lethal manifestation globally. If we look at the United States, the CDC's ABC surveillance system provides high quality lab confirmed data on invasive pneumococcal infections. Here I am sharing the framework under which EIP operates, enabling real time tracking of invasive pneumococcal disease trends, resistance patterns, and vaccine impact. These surveillance efforts are critical for evaluating policy recommendations and tracking emerging serotypes. The ABC's network gathers data from 10 states with a combined population exceeding 35 million. These geographically diverse regions contribute data that serve as a proxy for national estimates. Surveillance reveals persistent disease burden despite vaccine availability, particularly among older adults and those with chronic conditions, indicating gaps in vaccine uptake. We know that pneumococcal conjugate vaccines have evolved in response to epidemiologic surveillance. Each vaccine form, from PCV7 to now PCV21, has sought to cover emerging serotypes contributing to invasive pneumococcal disease. The key advantage of PCVs lie in their ability to induce robust T cell dependent response and hence establish immunologic memory. PPSV23, in contrast, has broad serotype coverage but provides suboptimal protection in older adults due to poor immunogenicity. The challenge remains in balancing breadth of coverage with depth of immune response. Now, this timeline illustrates CDC's evolving guidance. PCV7 was first introduced in 2000 for pediatric use, triggering indirect protection in adults via herd immunity effect. The introduction of PCV13 in adults aged greater than 65 was in 2014, and that was a pivotal moment. But recent shift towards shared clinical decision making reflect concern about cost effectiveness and diminishing returns of herd immunity. PCV15 and PCV20 are now preferred for adults, as I will show you in the next coming slides, and they provide expanded serotype coverage with streamlined administration. Global introduction of PCV7 led to dramatic reduction in childhood pneumococcal mortality. This WHO UNICEF dataset shows a 51% decline in pneumococcal related deaths in HIV negative children up to the age of 59 months between the year 2000 and 2015. The reduction is a composite result of both direct vaccine efficacy and indirect benefits through reduced transmission. Importantly, this success supports expanding pediatric immunization in low resource settings. This map-based analysis estimates that 60% of the child lives that could be saved by PCVs are concentrated in just 20 countries. These countries, many of them are Gavi eligible, represent the highest yield targets for investment in vaccine delivery infrastructure. Bridging this gap is critical, especially as a newer vaccine like PCV20 and PCV21 are being rolled out predominantly in higher income countries first. The introduction of PCV13 in adults aged greater than 65 coincides with a substantial drop in invasive pneumococcal disease incidence, 64% in children less than 5 and 32% in older adults by the year 2019. The figure demonstrates a serotype-specific decline over 2 decade span. However, serotype 3 remains a persistent challenge, with limited reduction despite inclusion in PCV13, possibly due to its poor immunogenic profile. This raises questions about the real-world effectiveness of conjugation for certain serotypes. This prospective study, involving more than 1,400 adults hospitalized with radiologically confirmed community-acquired pneumonia, found that PCV13 and PCV20 serotypes accounted for 37.7% and 27% of cases, respectively. Serotype 19A, 3, and 22F were the most frequently detected. The data support broader implementation of urinary antigen detection assay as well, and suggests that next generation assays covering additional serotypes could improve diagnostic yield and guide empiric antibiotic therapy. Data from Tennessee and Georgia reinforce earlier findings. Of 2,917 community-acquired pneumonia hospitalizations, Streptococcus pneumoniae was confirmed in 12%, with 51 cases of invasive pneumococcal disease. The most prevalent serotypes align with those in PCV20, supporting its continued use. These findings also suggest that even with widespread pediatric immunization, adult pneumococcal disease remains a significant cause of hospitalization. Vaccination has secondary benefits beyond infection prevention. It reduces antibiotic use and thereby limits selective pressure for antibiotic resistance. The ABC's data set is particularly useful for tracking trends in antimicrobial susceptibility. Decreases in vaccine-covered serotypes often coincide with reduction in resistant isolates. However, non-vaccine serotypes are increasingly expressing resistant traits, highlighting the importance of continuous molecular surveillance. This is one of our QI initiatives that targeted hospitalized adults with COPD, asthma, or tobacco use. Prior to admission, only 42% were adequately vaccinated. After intervention, 46% of eligible patients received PCV13, 26% received PPSV23, another 26% actually declined vaccination, emphasizing the role of patient hesitancy. Educational initiatives, standing orders, and EMR-based prompts may improve uptakes, especially among high-risk groups. We know that serotype replacement is a well-documented consequence of selective vaccine pressure. The CERNET study, analyzed across 42 sites, showed significant emergence of non-vaccine serotypes like 15A and 23B. These replacements vary by geography, influenced by local epidemiology, and vaccine schedules. This underscores the need for adaptive vaccine design guided by longitudinal serotype surveillance. Now, this graph shows the most common serotypes causing invasive pneumococcal disease 5 years post PCV introduction. Serotype 3 leads among both children and adults, followed by serotype 15BC and serotype 8. Despite inclusion in PCV20, coverage gaps remain. Serotype 15A and 23B, currently unaddressed by licensed vaccines, are gaining ground, particularly in older adults, reinforcing the importance of broad spectrum serotype inclusion in future formulations. Now, cost and supply chain barriers limit vaccine access in low and middle income countries. Despite global need, over three-fourths of the economic benefits from PCV implementation occur to high-income nations and manufacturers. Cross-subsidization and pool procurement mechanisms, similar to Gavi's model, could better align vaccine pricing with local value generation and reduce inequities in that way. Here I'm sharing the pneumococcal vaccine schedule for the United States, primarily based on the information shared by ACIP and CDC. These vaccine schedules are really helpful for the primary care providers for easy decision making at the time of clinic visits. Apart from childhood pneumococcal vaccine recommendations and pneumococcal vaccine recommendations for adults aged greater than 50, there are some specific indications for pneumococcal vaccination in adults between the age of 19 and 49 years who have immunocompromising condition, CSF leak, cochlear implant, or chronic medical conditions. After going through all that discussion, I can say that future lies in serotype independent approaches. These include recombinant pneumococcal protein targeting conserved virulence factor, nanoparticle packaged antigen, and hybrid protein polysaccharide conjugates. Early phase nucleic acid vaccines, including mRNA platforms, are also being explored. The goal is to elicit broad, durable immunity without requiring constant reformulation in response to serotype shifts that we have seen. To summarize, pneumococcal vaccination has dramatically reduced invasive pneumococcal disease incidence and mortality. Yet challenges remain, primarily serotype replacement, persistent disease and high risk growth, and global access disparities. Future strategies must prioritize broader antigenic coverage, enhance immunogenicity in vulnerable populations, and equitable access of vaccines across the economic strata. Thank you for listening to this presentation.